topic is on role of external fixators in tibial osteotomy. I think I'll mostly concentrate on the clinical cases. Just look at this 49-year-old man with medial knee pain and reasonably good-looking knee joint for a 49-year-old man. He came with this. He had a total knee replacement. Just imagine, suppose you are taking your car to a alignment center, just by seeing a little bit of wearing on the thread. And if the shopkeeper says that you change the tire, will you change it? So we are taking regularly every 2,500 kilometers, we take our car for alignment check to save a few 10,000 rupees on our car tire. But how much your knee cost? Have you checked your alignment any time in your life? So she's a close friend of mine. She had severe knee pain. That is the arthroscopic finding. We can see the medial condyle of the femur. It's completely gone, and she has been advised a high tibial osteotomy. And she has referred to me. See, that was how her X-ray was looking like. Should we go for joint replacement or do a high tibial osteotomy or do a total knee replacement later? And this is a full-length X-ray. As Mangal said, if you just see only the knee joint, the real enemy may be somewhere away. So here you can see the femur is bowed, and actually she and tibia is practically perfect. And she has femoral diaphyseal virus on both sides. And we have to do a femoral diaphyseal deformity correction rather than an HTO for her. So that means a malalignment in lower limb, anyway, from hip joint to the ankle, affects mechanics of the knee and results in secondary osteoarthritis of the knee joint. So as Mangal said earlier, how the loading goes across the knee. This is our first year MS learnings. When you don't have any deformities, that is, when you fairly straight bone, straight knee joint, you have 70% load happening onto the medial condyle of the femur, tibia. When you have 2-degree virus, it is 75 degrees. Just think about 6-degree virus, it comes about 95 degrees. 95% load there. And 4-degree valgus, it's about 50%. That's at the Fujisawa point. And when you have 6 degrees, the medial condyle will take only 40%. So most recommend to realign for 2 to 6 degrees of valgus, and results are deteriorated with more than 6 degrees. I usually stop at 4 degrees, 2 to 4 degrees. So this Fujisawa point is already been described by Mangal earlier, and that is a point where you have 50-50 loading on either side. And as Mangal said, when you take an X-ray in a stress view, you assess the cartilage space, how much is the space remaining on the X-ray. And based on that, we shift the mechanical axis to the future mechanical axis to either 1/3, 2/3, or full Fujisawa point. When you don't have any loss, that the cartilage is very good, you take to center of the knee joint. When you have 1/3 loss of the cartilage, you take it to 1/3 of the Fujisawa point. When you have 50%, when 2/3 lost, you take it to 2/3 part of the Fujisawa point. When bone on bone, you take it to the full Fujisawa point. So you cannot, HTO is not an answer for all the problems. I think it's better, HTO corrects the deformity, but it's only part of a realignment strategy. So we cannot stick on to everything you cannot fit everything for HTO. So there are femur deform corrections and there are so many other concepts on that. So the realignment strategies of unique compartment osteoarthritis, the goal is to preserve the knee joint and delay TKR as long as possible. And if possible, one human being should have only one primary TKR in their lifetime. So preferably after 70 years. And our aim is that they must remain a optimal take care candidate in future. So that is why in opening wedge HDOs, it's often done below tibial tuberosity. It's a bone enhancing procedure, and there is no additional difficulties to do a take care in future. So, but the problem here is, can one osteotomy like HDO can solve all medial compartment osteoarthritis? Yeah, it can never do that. So you have to do a customized osteotomy like an a la carte approach, treat each case in a customized fashion. All medial boy, you cannot do a HDO. So you have to find out where exactly the deformity is. By malalignment test, find out whether you have what is the femoral component, what is the tibial component, and find out the real core of the deformity, and what type of osteotomy you are going to do, how much magnitude of correction you are going to do on that, and stability and instability of the knee joint as such, and what type of fixations. The magnitude of the deformity, usually what I do is most of these cases I do by Ilidoro. So I plan for an angular deformity and I consider the joint line convergence angle also along with this, because since I am doing an Ilidoro, I can do a little bit over correction or under correction at the end of it, because you can fine tune it perfectly well. And if you do the osteotomy above the tuberosity, it needs only an angulation. It's simple to correct, but closing has its own problems like lax patellar tendon and truncation, which can create a trouble for for a talk take care later. When you in open wedge osteotomy, when you above the tibial tuberosity, that tightens the medial ligament, and that too tightens the patellar ligament. And sometimes you may have to do a graft or a special type of plates. And before doing attempting any case or for these corrections, you must know what we are doing. Where are we going to do it? Which bone, the femur or tibia, am I going to correct it? How much I have to correct? And how I am going to correct it? An external fixator is only a tool. So you don't have to stick on to the external fixator. All cannot be masters of all tools. Some people are excellent with nails. Some people are excellent with plates. Some people are good in all. So whatever may be, the result should be the final planning and final correction. So stick on to that. That gives the result, not the tool. The final end result is the one which is going to give the result. So we can discuss the benefit of one method over the other. And each one has its own merits and demerits. So look at this 52-year-old man with a lateral knee pain. He was advised a total knee replacement. See, the lateral joint is very badly damaged. It's only 52. And that is the X-ray looking like. Obviously, when you look at it, you can see a valgus deformity, but the femur isn't severely varus. When you look at the X-ray, you tend to do a varus correction of the femur. When you do the varus correction, the valgus will become more and more obvious. So that is not going to solve the problem. But when we planned the whole thing, I found femur is reasonably well compensated and he need only a tibial correction. So that means all valgus you cannot correct in the femur. Here you have to correct on the tibia. So the old rule, like whenever you see a valgus, you correct in the femur. Whenever you see a varus, you correct in the tibia. It's not right. And here I used external fixator because when you do an acute valgus correction in the tibia, it can cause a peroneal nerve palsy. So I need fixator here for very, very slow correction. And never ever overcorrect it into virus. Because when you perfectly aligned, 70% load goes onto the medial compartment. And you can see the lateral compartment got opened out. And you can even squat it. This is a result after 5 years. The X-ray is after 3 months. So this is another 55-year-old lady complaining medial knee joint pain more than 1 year, and she had a strong family history of similar illness. And you can see the right side is worse than the left side. And you can see the mechanical axis planning. The medial side has gone, the left side has gone medial to the joint. Right side is also on that. So when you look at it, you can see even in the upper end of the hip joint, there is a mild coxa vara And there is a distal femur varus. There is a proximal tibial varus. MPTI is only 83 degrees. There is a JLCA 5 degrees. And there is a LDT of 91 degrees. So everywhere it is varus. Upper end is varus. Distal femur is varus. Proximal tibia is varus. Distal tibia is also in varus. And this is how I do a Murphy line, because I don't, since I'm doing what I did the proximal mechanical axis. This is the future proximal mechanical axis. I think my mouse is not working. You can see the proximal mechanical axis going to the Fujisawa point, and that is the mid-diaphragm and the tibia. It goes above the knee joint. So that shows there's a femur deformity there. Then I shifted that line to the future osteotomy line, and the magnitude of the deformity is 17 degrees. So if I do an osteotomy at that level, and if I do about 17 degrees of correction, then I will make the mechanical axis straight like that. So this is going to be the final correction. So you can see that the fixator on the patient, a small osteotomy, and the hinges and distractors there. And this is after correction. So now we have made it straight, and we got perfect correction. But look at the big toe, left big toe, and the toe nail. You can see it is a little bit of rotated. So this is a problem which we usually see in some of these patients, long-standing cases, when there's already a subtalar joint a little bit valgus. When you do the valgus tibial osteotomy, it turns out to be a little more onto the valgus side, and they may develop a ingrowing toenail on that area. So I'll show you one more case. A 55-year-old anesthetist and medial tibial pain and multiple incidents of stress fractures on the medial side. See, the mechanical axis goes to the medial side of the knee joint, and his femur is perfect. But look at the tibia. His MPTA is 77 degrees and LDTA is 82 degrees, distal tibial valgus. Suppose I am doing a high tibial osteotomy for him like this. His angle will become more valgus. And that will worsen his angle problem, when this walking will be difficult in that time. So I replant it again. And that is the line. Now you can see the proximal tibial mechanical axis, distal tibial mechanical, they purely translate. So if you do a high tibial osteotomy, many of these people will develop ankle pain, ankle problems, and foot pain, and they'll develop acquired flat foot and tibialis posterior dysfunctions, and all can cause by this thing. So I have decided a middle line and plan to do 2 coras and double correction. And that is how I plan. You can see the original X-ray, and that's the planning. So at a 2-level correction, I can perfectly align this limb and correct this translation. So that a translation can be corrected by double angulations. That is upper tibial correction, that is the distal tibial correction, and that is the final go. You can see finally it is well corrected. You can see the full length X-ray. Now I got into the Fujisawa point. So that is the use of external fixators in HTO. We can literally play with the bone to get perfect correction and plan it very well. Thank you.